Welcome back to another session on critical care training and discussion. And this is the third lecture in the series of mechanical ventilation. Today we are going to discuss about liberation from mechanical ventilation. So what are the learning objective for this session is about the clinical steps to be considered when we are considering liberation from mechanical ventilation. What are the cardiopulmonary effects of positive pressure ventilation and what happens if we discontinue the ventilator. We will discuss the process of liberation and for exam point of view whether it is simple, difficult, prolonged, what are the various definitions as per the various studies. Is the patient clinical ready for giving the spontaneous breathing trial, that is SBT? What are the various weaning indices which are often used? These are CROP, that's compliance, resistance, oxygenation, pressure, or RSBI index and P.01. What happens with the fluid overload and weaning failure? We will cover the various reversible factors leading to ventilatory failure, and we will touch upon the weaning in special situations. Of course, we will have another lecture on this special situations of COPD, IHD or disease specific ventilation. So let's start. First is the terminology. There are three different terminologies here. Weaning, that is weaning from ventilatory support, is used. Often discontinuation of mechanical ventilation is also used, and I prefer the term liberation from mechanical ventilation. If you say the terminology weaning or weaning practices or weaning from ventilator, there is some slowness in that. If you see, most of the patients are able to get liberated from ventilator faster, and if we follow the traditional weaning process like taking the patient on SIMB pressure support and then taking on pressure support and then taking on TPs, it takes a longer time, and that's why the weaning terminology itself slows down the process, increases the length of stay, increases the duration of patient on mechanical ventilation. Another terminology, discontinuation of mechanical ventilation. Discontinuation term imbibes some negative feeling, like you're discontinuing something which is important. So discontinuation often we do in patients with brain dead who are declared dead, and we discontinue the ventilator. So a lot of bioethical principles are required when we consider discontinuation of a mechanical ventilation. The terminology liberation, that is what we do in day-to-day practice, and we will see how we can liberate the patient from mechanical ventilation and reduce the length of stay in the ICU, reduce the infection rate and reduce the VAP rate by liberating the patient of the ventilatory support. Now, what is the process of liberation? So most of the time, in 70% of the patients, it is a simple weaning, that is simple liberation. So you give a spontaneous breathing trial. The spontaneous breathing trial can be given for 30 minutes or 30 to 120 minutes. And if your patient is comfortable, passes the spontaneous breathing trial, in the sense the heart rate is stable, blood pressure is stable, oxygenation is maintained, sensorium is normal, cough gag reflex is good, then this 70% of the time this patient and the underlying problem is solved, can be extubated in 70% of the cases. The difficulty arises in another 30%, where initially if your spontaneous breathing trial fails, that means within 30 minutes the patient blood pressure rises, there is sympathetic surge, you can witness the increased work of breathing, you can witness there is a tachycardia, there is a arrhythmia, and that means the weaning trial has failed. That means the spontaneous breathing trial has failed, and you cannot continue that way. You have to wait for 24 hours, give the assist ventilation, and then again try the spontaneous breathing trial. If you subsequently fail for spontaneous breathing trial, you try finding the underlying cause for failure and try treating that underlying cause. But suppose you are failing 3 times and you take almost a week to take the patient off the ventilatory support, then this patient falls in the category of difficult liberation or difficult weaning. Prolonged weaning. Certain patients who have muscle weakness, who have quadriparesis, who have cervical spine injury and respiratory muscle involvement, or ARDS patients sometimes, where your 3 spontaneous breathing attempts have failed and you are taking more than 7 days for weaning. These patient comes under category of prolonged weaning. Most of the patient may be requiring the tracheostomy for better airway toileting in a prolonged weaning or prolonged liberation trial. So these are the 3 different forms of weaning. Only 30% of the patients fall in category of difficult weaning or prolonged weaning. Now, first thing, when you see the patient on ventilator, clinical steps involved is the first thing to come to your mind is this patient ready to wean, or whether this patient can breathe without a ventilator. So this is the question you should ask. You should prepare the patient accordingly. So sedation vacation, that is morning patient 6 o'clock, the sedation should be stopped, and when you are going for the round at 8 o'clock, you should be able to assess his neurological status, his underlying disease, whether it is reversed, whether he is communicative, whether his oxygen requirements come down to less than 50%, PF ratio more than 200, his minute ventilation is less than 10 liter, his sensorium is normal, you check his electrolyte, acid base balance, all are equal, and you have kept the patient nil by mouth, propped up position. So this is the clinical readiness which is required to assess the patient to be taken off the ventilator. And of course, in some patients you should also check for whether any elective procedure is planned on the same day, where you may like to defer this. So these are certain clinical readiness criteria which are very traditional, and you can reduce this by being liberal in this approach and reduce the ventilation to 25%. So some patients may be on the inotropic support. Is it a contraindication too for readiness? So check the dose of the inotropic support. A minimal inotropic support and you are ventilating, so you are increasing the duration of ventilation by 40%. So minimal inotropic support or noradrenaline requirement less than 0.1 microgram per kg per minute is not a contraindication. You look for the trends. You look for that last 24 hours, how the inotropes are coming down and tapering down, and that should not affect your decision to prolong the ventilation. Similarly, if there are 2 inotrope requirement, of course that patient is not clinically ready to be liberated. Certain minor factor, that potassium of 3.2 or less than 4.5 is not a contraindication. Mild acid base balance disturbance is not a contraindication for keeping the patient in category of clinical readiness of weaning, and such patients you can reduce the length of the duration by 25%, which has a significant economic impact as well as the significant clinical benefit for the patient to be taken off the ventilatory support. What are the other objective weaning indices? The most common objective weaning indices which was given by Tobin is a rapid shallow breathing index. What does it signify? In the numerator you have respiratory rate, and in the denominator you have the tidal volume which you take in the liters. So suppose the patient is breathing more deeply and less frequently, so respiratory rate is less than 30, and his tidal volume is adequately generated 400, then you can calculate, you will see this index is less than 105. So what they say is that the index if less than 105, it's like we calculate in this patient. So RSBI is 30, so it's RSBI for the respirator of 30. So patient, we keep the frequency of 30 divided by, if tidal volume is 0.3, or we take 0.3, so this comes out to be 100. So it is less than 105. So if it is less than 105, there are chances that this patient may be weaned off, but again it signifies that the patient is breathing more deeply and less frequently. So this is the arbitrary figure. Lesser the value, better the chances of weaning. So RSBI should have a lower value. That means your denominator must be higher, the tidal volume liter must be higher, the respiratory rate must be lower. So that is how you can reliably calculate the RSBI at various interval as well as. So if you can calculate at 30 minutes, then you can calculate at 120 minutes, and the difference in the RSBI will also tell you whether you are going to have a weaning success or weaning failure looking at the trends. So you can take a single value or objectively carry out the values at frequent interval. Another weaning index which is a little bit complicated, like checking for the compliance into the inspiratory pressure into alveolar pressure, arterial pressure divided by alveolar pressure divided by rate. So this has been studied and they found that the value of 13 in this patient signifies weaning success. Again, this weaning indices need to be checked as at 0 time, 30 minutes or 120 minutes, and every weaning index will have its positive predictive value or negative predictive value, or ROC, that is the ROC receiver operative curve, and most of the times we need a curve to cover 90%. So if the ROC curve covers the 90% of the value here, then it is the significant weaning index, like in any other parameters we check. So true positivity versus true negativity, sensitivity versus specificity. So we want both and the ROC curve. P01 is a variable of interest. It's often forgotten. P01, what is P01? Is a pressure at 100 millisecond. So when the inspiratory wall is closed and just opening, and it is a marker of the patient drive, how much pressure the patient can generate. So this value nowadays, you on the ventilator, it gives directly you the you can see the P01 at pressure at 100 millisecond, and these are the three ranges which are seen. In the red you are seeing if it is more than 3.5 centimeter of water, that means the respiratory drive is higher, and that means what your pressure support assistance you are giving to the patient is less. He is demanding higher drive. If it is 1.5 to 3.5 centimeter of water, this is considered as normal, and this is patient, the chances of weaning success is higher. So if you take the patient from pressure support to T-piece, he will remain on T-piece, so the chances of success is green, or that is higher. If your P01 value is less than 1.5 centimeter of water, so if the patient is actually having a lower drive or over assistance, or his drive is less, so these chances of failure are very high if the P01 or value is less than 1.5 centimeters. So this can be checked with an additional tool for you when you are weaning the patient of the ventilatory support. Now most important is cardiopulmonary interactions. So why the weaning failure? What are the various cardiopulmonary interaction taking place? So when you are breathing in positive pressure ventilation, the heart is actually supported, heart is squeezed, your preload decreases because of the pulmonary vasculature being compressed by the positive pressure ventilation. The preload to the left heart is reduced. So you have reduced preload and reduced afterload. Because of that, the squeezing effect on the heart, and it is benefited. But what happens when we switch from positive pressure ventilation to a negative pressure ventilation? So venous drive increases, your oxygen requirement increases. So there is an increased sympathetic surge, patient has an increased preload, there is increased venous return, heart has to pump at the higher level. So there is an increase in the heart rate, increase in the contractility because of increased work of breathing. You are shifting the work of breathing from ventilator to the patient. So naturally the requirement is high, and this signifies the stress test. This is like a stress test on the heart, like you do the treadmill test. So you are taking the patient off the ventilator, you are actually doing the stress test where the increase in preload, increase in heart rate, increase in oxygen requirement, and increase in myocardial oxygen consumption, all this leads to increase in myocardial ischemia in a patient who are already vulnerable, like patient with congestive heart failure history, patient with IHD. There are high chances of weaning induced pulmonary edema, and this is what can lead to weaning failure. Very important parameter to see, to have a history and to keep in mind this cardiopulmonary interaction when you are weaning the patient, and you can prepare accordingly. So you can prepare the patient with the nitroglycerin sometimes, or with a diuretic, with a cardiotonic agent before you take the patient off the ventilator in such situation. So optimize, medical optimization. Fluid balance, in ICU is often a marker of outcome in patients. So most of the times we drown our patient in fluids. They are drowned in normal saline. So by the day 3 you will see they are in the most of the patients, 80% patient positive fluid balance. We forget to manage the balance at day 3, and this is the important point, because initially we try resuscitate, we keep on giving fluids, and then we realize that on day 3 we fail our spontaneous breathing trial. We see that there is rise in the heart rate, arrhythmia, increase in BP, and all because of the fluid overload. Some biomarkers like serum BNP is a good marker of fluid overload. If it is more than 200 milligram from baseline on day 3, or if it is you are doing at one time also, if it is higher value, signifies that patient is in positive fluid overload. And there was a study where they did this biomarker and they did the preemptive diuresis in this patient. Preemptive diuresis made the patient negative. Some patient they put on nitrates and they found that the weaning success was higher in this patient compared to those patients whom they didn't do the BNP and they didn't analyze the fluid balance. So the two most important things we learned is, one, the cardiopulmonary interaction, see that it is like a stress test to the heart, optimize it, and second, the fluid balance, it has to be slightly negative or euvolemic, but should definitely not be the fluid overload, because that will increase the extravascular lung water, add on to our weaning failure. What are the other factors leading to weaning failure? So simple problems of resistance and compliance. So resistance, we know that the tube is in the situation, it stimulates the trachea. In vulnerable patient there can be bronchospasm. The tube itself will increase the mucus secretions, or there is a blockage of endotracheal tube. So you have to use inhaled bronchodilator, suctioning of secretion, and identify the upper airway obstruction. These are the all ancillary care required for the patient before you make him ready for weaning. Sometimes there is a reduced muscle strength because of the iatrogenic effect. We are using various drugs like aminoglycoside, corticosteroid for various reasons, and these may prolong the mechanical ventilation. Those patients whom we are unable to wean, like we discussed, prolonged weaning after more than 3 spontaneous breathing trial failure, more than 7 days, this patient may have additional problems like residual sedation, paralysis, or can lead to chronic critical illness neuromyopathy or critical illness neuropathy. These are the things which we should keep in mind, and glycemic control and the trace elements like calcium, magnesium, phosphorus in the patient who we repeatedly fail to wean. So correction of these above factors should be kept in mind, and always when there is a weaning failure, try to rule out the cardiac cause, try to rule out the fluid cause, try to rule out the what are the underlying any drugs, sepsis, malnutrition, electrolyte derangement. This has to be corrected, bronchospasm has to be corrected. What are the other causes? There is a new developing pneumonia, that's why you failed, or patient develop pulmonary edema. There is negative pressure pulmonary edema sometimes, and there is reduced dynamic hyperinflation. So you have to reduce this dynamic hyperinflation if you want to be successful in weaning. Detect the intrinsic PEEP. So if you can detect the intrinsic PEEP on the expiratory graph curve we discussed in our graphic sessions, or you can put an expiratory hold and you can check for the intrinsic PEEP. You can check the X-ray or USG to find out whether there is any pleural effusion that is hampering your weaning, or you are missing some pneumothorax which has to be picked up, or there is the abdominal condition because of the distension of abdomen, or because of the paralytic ileus, or because of the like in cervical spine patients you'll see that abdominal distension itself is interfering with breathing, already compromised lungs. So treat the ileus seriously. These patients are in the ICU for prolonged period, and it is to be overemphasized that you should screen for pulmonary embolism. Don't forget this life-threatening complication. These are the bedridden high-risk patient. Maintain the least PEEP possible. Correct the metabolic acidosis if there is any. Resuscitate the shock or circulatory component, because this may also lead to weaning failure. In certain COPD patients, if we are overfeeding, we are increasing the CO2 load, and that will increase the respiratory drive, and that will increase the respiratory burden, and so avoid overfeeding also if you want to wean the patient properly. So identify these reversible causes and then you go ahead with the individualized weaning in such cases. What is the weaning in special situation? As I told, we will be having a separate session for disease specific ventilation. Here I will touch upon the obesity. We know that obesity, there is a may repeatedly desaturate every time the PEEP is decreased to 10 centimeter water. There is atelectasis. We discussed the concept of transpulmonary pressure in my first lecture, and we found that if the transpulmonary pressure is positive, then there is a chances that it's a difference between alveolar pressure and pleural pressure, and when the pleural pressure becomes positive or the transpulmonary pressure reduces, there is the atelectasis. So this holds true in the obese patient, where you may have to keep a higher PEEP is to decrease and you may have to break the rules. That means you have to take the patient on pressure support ventilation for weaning rather than giving the spontaneous breathing trial. This you have to decide individually, or sometimes you may, if the patient is planned for extubation, he's conscious, sensorium holding, there is no secretions are he can hold the secretion, his oxygen requirement has come down, there you may extubate the patient and take on NIV. This is also we practice in some COPD patients also, where we can switch to NIV. So these are the individual decisions in disease specific ventilation weaning we will discuss. Here I just told you how you have to individualize the weaning in individual patient. Coming to extubation, there are 4 points important here. First thing, weaning or liberation of patient from mechanical ventilation and extubation. These are the different things. So discontinuation or disconnecting the patient, he is taking spontaneous breath, but he may not be extubation ready. So extubation is a different criteria. So what you require is a good cough from the patient. You require a good cough gag reflex. He should be able to hold his secretion. He should be able to cough out. So adequate vital capacity is required and his sensorium is normal. Then only you will consider the extubation criteria, otherwise you will fail. There are certain other tests like cough leak test you like to do if you feel that airway edema, patient has prolonged ventilation for more than 7 days, you feel that there might be some laryngeal edema, the intubation was crash. So if you feel vocal cord injury, here you can do the simple cough leak test. So take the patient on pressure support ventilation, do the subglottic suction, keep the NBM, and then deflate the cuff. If there is a cuff leak or there will be cuff leak, you check the expiratory tidal volume before the deflation of cuff and after the deflation of cuff. So after deflation of cuff, naturally if there is space around the tube and you feel that there is a air leak here, and the air leak can be calculated from difference between expiratory tidal volume more than 110 ml. That is significant. That means there is less likely that the patient will have stridor. If it is less than 110 ml, beware that this patient may require intubation or avoid extubation because the cuff leak test is positive. You may try corticosteroid if you feel there is a airway edema, methylprednisolone 12 hours prior to extubation, or hydrocortisone. There are studies, so this has to be given in such situation. Now post extubation, if there is a minimal stridor or minimal oxygen requirement, you can put on nasal cannula. Sometimes if the work of breathing is high, you have to try for high flow nasal cannula or a BiPAP or a Venturi mask. So this again will be depending on the situation. So if the patient has having increased work of breathing after extubation, but he is able to hold the secretion, his conscious level is normal, so you may have to go for the BiPAP ventilation temporarily. Or if the patient has a stridor or minimal or moderate amount of stridor, high flow oxygen is a good choice to avoid the intubation in such situation. So that is about the liberation from mechanical ventilation. Thank you for listening. If you have any queries, reach me out at practicaltips@gmail.com.